Now I invite Dr. Alouche to present next speaker.
Thank you, the next speaker who is going to talk about best practices and art organization is HIV clinical trial during the COVID pandemic in East Africa is Dr. Lois Achieng Ombajo, who is a lecturer at the University of Nairobi and consultant and head of infectious diseases hospital at the Kenyatta, and also scientific secretary for the HIV Clinician Society. But above all, a very active research in HIV and COVID, and currently she's the head of all HIV scientific, COVID studies and activities in North Africa. She's a great lady, so can I introduce you? Can I present to you, Lois Achieng Ombajo?
Good afternoon, everyone. Thank you, Dr. Lodge, for that very kind introduction. And thank you to the organizers for inviting me to give this talk. So I think Dr. Lodge set a very good sort of background to what we're going to discuss today. And it's really around how ART provision has been during this time of COVID, as well as some experiences around our own clinical trials and how to keep them going during an epidemic such as this. So this appeared by UNAIDS earlier in the epidemic. I think it was about April or May. And they talked about COVID-19 and HIV being, that one moment where there were two epidemics and opportunities which we needed to take to sort of leverage the response to COVID based on what we'd learned from HIV, as well as leveraging some of the resources that are available for HIV for the COVID response. Not all has worked as per plan, but looking at the Kenyan scenario, we have truly two epidemics. One is that we have a fairly large HIV epidemic, the HIV prevalence of about 4.9%. This ranges from as high as 19% in some regions to as low as 0.2% in certain areas. But at this point, we probably have just about 1.5 million people living with HIV. The ratio of female to male being just about 2.1. And we've continued to have a fairly high annual incidence. So we have high HIV prevalence. Then going on to the issues around optimization. We've done really well with issues of optimization for first-line therapy. Most patients are currently on a dolutegravir-based regimen. Our second-line therapy continues to be a PI-based regimen, and our guidelines are currently undergoing review with the aim of sort of harmonizing with the WHO guidelines. And one of the major changes currently is including all patients who are currently on efavirenz, so women of childbearing age, being transitioned onto dolutegravir, and as well as looking at the option of switching the PI in second line to dolutegravir. So those are sort of the changes that we're looking forward to. But we've done a lot of work with the National HIV Program to ensure optimization of ART regimens for most patients in country. So if we look at COVID, we've sort of had a bit of a roller coaster, so to speak. We had our first case reported on the 13th of March, and we had our initial very highest incidence around early July. Actually, most of July is when we had the highest number of patients in hospitals. We also had a significant mortality around that time. Towards the end of August and early September, we had a smaller number of patients who were testing less, but nevertheless, our hospitals had much fewer patients than we'd seen earlier in the epidemic. And around this time, a lot of restrictions were lifted. And what we're seeing currently is a significant rise in the number of cases that we're seeing, in the number of severely ill patients. Many of our ICUs are full, and hospitals are getting rapidly full. So far, we've had a total of just about 60,000 cases and just over 1,000 deaths. If we look at some of the measures that were put in place to try and control the epidemic, so we have the first case around the beginning of March. Just soon after that, a few days after that, there was a closure of schools. There was a ban on international travel, and all Kenyans coming to the country had to undergo quarantine. either self-quarantine or quarantine in a facility for at least 14 days with testing after that. Then shortly after, as the cases began to go up, especially in the capital city of Nairobi, there were significant travel restrictions into and out of Nairobi and Mombasa, which were the countries reporting the highest incidences at the time. There are also other things put in place, including wearing of masks and, streamlining of public transport and curfews, dusk to dawn curfews that were put in at the time. And this had been in force for a few months, but of course, COVID fatigue sets in. There was a lot of impact on socioeconomic aspects of people's lives, and some of these restrictions started to get lifted. And as the restrictions were lifted, we began to report an increasing number of cases. And most recently, restrictions were lifted towards the end of September. And after that lifting of restriction, we've seen a big bump in the number of cases. And that's where we are now, with significantly high positivity rates. And the reason I bring this is because as we go on, we'll see what the impact of some of these restrictions, both on HIV care and on our clinical trials, have been. So if we look at impact of COVID on other health services, and this we look at our DHIS data and try to track what different indicators over time. And I just picked one of those indicators, which in this case is the outpatient attendance workload. And if you look at each of these bars, there's 2018, 2019 in the darker color, and 2020 in the green color. And at the beginning of the year, you can see that outpatient attendance was just a little above what we'd seen in 2019 and 2018. But after the outbreak in March, so if you look at April, May, and July, we had significantly fewer patients going into health facilities as compared to what we've seen during similar periods in the previous months. And in October, as the cases went up significantly, again, outpatient attendance has suffered quite a bit. So clearly, patients who have non-COVID issues may be staying away from home. This may include many HIV patients. So looking at the HIV program, at the initial phases of the outbreak, the National HIV Program made a decision to give patients longer prescriptions. So patients were given prescriptions for up to 6 months. This also came at a time when we were rolling out the differentiated care program, where patients who are doing well were being given longer periods of time between clinic visits. There was also a program decision to ask patients to pick medication from the clinics nearest to them, so they did not have to travel to their usual clinics. Made sense at the time because our transport had been impacted significantly by some of the restrictions brought about by COVID. There are also changes in patient flows within clinics. Many patients spent the least amount of time within clinics, and this was really just to try and minimize contact with healthcare workers and anyone who might potentially be infected. As I mentioned, there are travel restrictions. For example, for us working in Nairobi, we're not able to get out of the city. No one was coming into the city. So any patients who are being treated within the city had to find alternative clinics for their medicines pickup. The transport changes also made traveling quite expensive. We also had infections amongst our patients. And when we look at our database, our last study looking at just over 800 patients, found about 7% of the patients with COVID also had HIV infection. Unfortunately, many patients had never been in care, and now because of the acute illness brought up by COVID, they were presenting to hospitals for the first time with various opportunistic infections as well as COVID. And for the sickest patients, again, outcomes were not the very best. There's also a reassignment of HIV infrastructure to COVID. My apologies for that. So, for example, a lot of the HIV viral load platforms were now doing COVID PCR testing, which means a lot of the personnel who were doing HIV viral load testing were now rededicated to COVID PCR testing. And what we've seen is a significant delay in HIV viral load turnaround times for many of the programs. So I'll just later look at some of the solutions to many of the challenges we had. But I first wanted to start by just sharing experience that we've had from one of our clinical trials. So this was a second-line clinical trial, and we're looking at switching treatment experience, integrase inhibitor naive, virally suppressed HIV-infected adults from a PI ritonavir-based inhibitor to dolutegravir. And this would really inform our current strategy of hopefully changing patients who are on second line from PI based to a dolutegravir based regimen. So we call this the 2SD study. And basically, the background was that almost all our second line patients, currently we have somewhere between about 80,000 patients who are on second line, all of who have been on either tazanavir or lopinavir, ritonavir. But of course, we'd had several challenges with PIs. One, the issues of pill burden for those who are on lopinavir, issues of tolerability, toxicity, even for those who are on atazanavir, who often are complaining of issues like jaundice, and drug interactions. So for patients who are on TB treatment, we've had significant stockouts of rifabutin. So many of these patients would end up being switched to DTG just to enable the TB treatment. And of course, previous data showing DTG to be superior to PIs as first line. And more recently, the Donning trial showing that DTG was superior to lopinavir, ritonavir in patients failing an NNRTI regimen who had a fully active NRTI backbone. So based on this, we really wanted to evaluate what the efficacy and safety of switching patients on second line from a PI to DTG-based regimen was. And I've just mentioned that. So again, what we're looking at was protocol-defined viral failure, which would be 2 consecutive viral loads of greater than 50 copies per ml. So this was our design. It's multi-center. We are conducting this study at 4 centers, randomized. It's an open-label non-inferiority trial. And we're looking at enrolling at least 766 patients with 383 in either arm. So at the time, we started enrollment in just end of January. The blue line here sort of shows what our projected enrollment was. At the time that we had the first case of COVID, you see, in the initial stages of enrollment, we actually surpassed our projected enrollment. Then came just about March when the first cases of COVID were reported, and our enrollment went down significantly. And where we had hoped to have finished enrollment by month 6 of the study, we had still not completed enrollment. Now we have completed enrollment, but it took us 3 months longer than was initially expected. Some of the challenges that we had was, one, the issues of travel restrictions were quite severe. So many patients were unable to come physically to clinic. There was a lot of participant anxiety, and most people preferred to stay home. People were scared of taking public transport and of coming into clinics because hospitals were seen as a place where COVID patients went to. We also had healthcare worker exposure. And remember, at the beginning of the outbreak, we had to send out some of our study nurses and clinicians who had been exposed to patients with COVID while in the clinic, and we had to send them to quarantine. So that again took away some of the, the workforce that was responsible for participant enrollment. There was significant increased cost because public transport providers were required to carry only about 50% of capacity. So they doubled the cost of public transport. And this had an impact on participant reimbursement of costs. Now, of course, there was a lot of loss of income, loss of jobs, and many people moved away from the cities to their rural homes. So following up participants who went to rural homes became fairly difficult. And then there was just this general fear and uncertainty about what would happen the next day. And some patients, because of the program decision to pick up meds from different locations, ended up going to other clinics. And we saw at least 1 or 2 instances where they were taken back to their pre-trial treatment regimen. So those were significant challenges around that time. Of course, some of the impact is one where we had study participants who would have lost. Remember, these trials are expensive. So where you've screened hundreds of patients and enrolled hundreds, to start screening all over again because of loss to follow-up would be very expensive. The significant impact on the study budget because we're now enrolling beyond our initial expected enrollment. We had to interact a lot with the ethics and regulatory boards to get new approvals, to vary some of our procedures, to call patients more often, to send people to patients' homes for purposes of follow-up. So it's been quite a long journey, making sure that the clinical trial goes on. But we had to get a little innovative, and some of the things we did. One, initially, we really had to train the healthcare workers, all the study nurses and clinicians around personal prevention, avail personal protective equipment for all the healthcare workers, redesign the clinic spaces so that we had some social distancing in the waiting areas as well as in the clinic rooms. We did a lot more virtual support for participants. So a lot of adherence counseling on phone. A lot of it was really around allaying fears of participants, because there was a lot of fear. A lot of participants did not even want to go to clinic. So we had to do a lot of counseling on phone. Where participants were unable to come into clinic, we had to deliver medicines to their homes. And occasionally we had a patient who was locked out of the city. And they were unable to come in during their week 4 visit, for example, where labs were required. And we had to send out lab personnel on motorbikes to go out to participant homes to collect samples and deliver medicines. And where that was not possible, we had to find a clinic nearby where we could enlist a clinician as an extension of our study personnel, so they could carry out some of the study procedures, ensure meds were taken, and do the adherence counseling. There's a lot of work that had to go into this process. And that's how we finally managed to enroll now close to about 790 participants. So having said that, I think one of the things we've learned is that it is possible to conduct a clinical trial. We shouldn't necessarily settle for less. It's fairly expensive, and we have to think about different ways of changing what we do with the trial. And this has also worked even for ART delivery, where we've had to really engage patients more virtually to ensure that they continue to take their medication. Thank you very much for your kind attention.